This is an educational presentation introducing healthcare professionals to synthetic cannabinoids, commonly known as K2, and populations at risk for use. This presentation was created by and will be presented by the University of Central Missouri Masters of Science in Nursing candidates Melissa Barkmeyer, Ann Gottfried, Elizabeth Moore, and Darla White. The goals of this presentation are to discuss cannabis and introduce K2, to identify current and potential users of K2, to explain presenting symptoms and adverse effects of K2, to discuss ways of testing for the substance, and to identify treatments and nursing interventions for users. Tetrahydrocannabinol, also known as THC, is the principal psychoactive component of marijuana. When administered under proper medical supervision, THC can be used in the treatment of several conditions and diseases such as glaucoma and cancer pain. THC-based drugs produce both therapeutic and psychotropic effects by acting on the CB1 cannabinoid receptors in the central nervous system. Ancient cultures dating back to 4000 BC have used cannabis-derived products to treat a variety of ailments and for religious ceremonies. In the late 19th and early 20th centuries, the dangers of cannabis became more recognized, and it was eventually outlawed after the Marijuana Tax Act of 1937. Recreational use grew rapidly and flourished in the 1960s and 70s. Use continues to be high today, with approximately 50% of the United States population admitting to trying cannabis at least once. Synthetic cannabinoid receptor agonists, or synthetic cannabinoids, are a large family of structures that are chemically unrelated but functionally similar to THC. They bind to the same CB1 cannabinoid receptors in the brain as THC. They have been developed over the past 40 years as potential pharmaceutical agents. In 1995, John W. Huffman at Clemson University synthesized JWH-018. It was first developed for experimental use. It produced similar effects in animals as THC, but was more potent. Mr. Huffman was interested in the effect of cannabinoids on the brain and the peripheral nervous system and their possible medical indications. Since Huffman created JWH-018 in 1995, several other synthetic cannabinoid compounds that target the same cannabinoid receptors have also been created. These compounds are still being created and changed, which makes them difficult to monitor and regulate. According to the Drug Enforcement Administration, despite over 30 years of research and investigation, no validated medical use for these compounds has been identified. This is a list of some of the many plants used as a base for K2. The synthetic cannabinoid compound is sprayed onto these plant bases and the plant is then smoked. This presents a dangerous problem because many of the plants themselves have psychogenic effects when smoked. The combination of the plant and the chemical can produce unknown reactions and effects. The substance is largely acquired on the internet, from head shops, in convenience stores, and gas stations. The substances are advertised as incense. They're sold where people can buy specialty tobacco and tobacco smoking accessories. K2 was banned in Kansas and Missouri in 2010. K2 is usually sold in colorful and appealing packaging. It's often advertised as incense and not for human consumption. Sellers claim that the substance is safer than marijuana and is undetectable through urine drug testing. This is a list of just a few of the names used on the packaging of K2. Users of K2 ingest it by smoking. K2 is rolled in rolling papers, which are also used for tobacco and marijuana, or it's smoked using accessories such as a pipe or a bong. The demographic groups most commonly using synthetic cannabinoids include teens, young adults, military, individuals who are drug tested, and prisoners. This substance has become popular among these groups for different reasons. There is a perception that K2 is safer than marijuana due to the fact that it was legal and could be purchased in gas stations and convenience stores. There's also the perception that it's not seen on standard urine drug tests. This makes K2 an attractive option for people who are drug tested for work, school, or military service. Adolescence is a developmentally vulnerable time, and it's the period when cannabis use is often initiated. According to the National Institute on Drug Abuse, among adolescents, the use of marijuana has surpassed cigarette use, and the perceived risk of danger of marijuana use is diminishing. Gender is an influencing factor in adolescent use. Males are more likely to use than females. Parental smoking and alcohol use influences use in teens. Heritable risk factors include psychiatric illness and familial patterns of substance abuse. Teens in inner cities and impoverished areas are also at increased risk. And peers have also been shown to influence teen behavior in all areas, including drug use. Professionals likely to encounter users of K2 include school safety officers, school nurses, paramedics, emergency department staff, family practitioners, and drug recognition officers. Nurses on inpatient units could also potentially care for the users of this substance, but use will likely be established by the time the patient reaches an inpatient setting. This slide is a reference table used by DRE outlining the effects of different types of drugs. This would be a useful tool for professionals caring for users of K2 as well as other substances. Some of the presenting symptoms and adverse effects of K2 are seizures, agitation, irritation, loss of consciousness, anxiety, confusion, paranoia, tachycardia, hypertension, chest pain, cardiac ischemia, hypokalemia, hyperglycemia, nausea and vomiting, fever, conjunctivitis. When presenting to a healthcare facility in crisis, patients can present with any or several of these symptoms. We, as providers, should keep this in mind, especially when assessing adolescents or people at risk with no other existing health condition. Although K2 is a relatively new substance, some of the long-term risks are cardiovascular disease, dependent syndrome, and altered mental and psychosocial development among adolescents. Research has indicated that prolonged use of this substance could lead to a higher incidence of schizophrenia and psychosis. Withdrawal symptoms from K2 can include excessive sweating, tremors, agitation, headache, sleep disturbances, and GI upset. These are symptoms that providers might see in an inpatient setting. These symptoms will require supportive therapy and monitoring. Due to the difficulty in detecting this drug with routine urine drug screen, patients in crisis might be evaluated for acute MI, psychosis, and/or panic attack. Gathering a complete health history is important to determine a plan for these patients and to potentially rule out cardiac and psychological causes for the symptoms. The urine drug analysis performed at most hospitals is not capable of detecting the synthetic cannabinoids, and while blood testing is available to test for 4 of the compounds, the 1-hour half-life makes sample collection difficult. Blood samples must be obtained almost immediately after ingestion. Although the half-life of K2 is relatively short, some of the adverse reactions, like muscular and psychological agitation, paranoia, hallucinations, and seizures, can last up to 3 hours. Treatment of K2 users in crisis include benzodiazepines for acute agitation, IV fluids for hydration, cardiac monitoring, and a low-stimulus environment. These are all supportive measures for patients under the influence of K2. There is no reversal agent to stop the effects. Nursing professionals providing care to these patients should obtain a thorough and complete health history, reduce anxiety with frequent reorientation, speak calmly and quietly, monitor vital signs, and educate the patient and family about positive and healthy ways to meet the patient's needs. In the adolescent population, there's a strong need to be accepted by peers. Sometimes this need is stronger than the teen's need to make healthy choices. Erickson's theory of modeling and role modeling can be applied to users of K2 and other substances. According to this theory, nurses should be sensitive to the user's perspective of his or her own world and nurture, teach, and role model more positive ways for the user to meet the basic needs that they perceive are lacking. As nurses and nurse practitioners, we need to recognize that this need is real in the adolescent's perception of the world. Validating this need, building a trusting relationship, and educating the teen would incorporate the modeling and role modeling theory into practice. In conclusion, K2 is just one of the many new and evolving designer synthetic drugs. As healthcare providers, it's vitally important that we are up to date and educated on this topic so that we can recognize these patients when they present to us and are able to treat them appropriately.